Hello everyone. Whether physician-assisted death should be a legal end-of-life option is a highly debatable subject. Today I will present why I support the legalization of physician-assisted death, or PAD. Presented here are a list of all end-of-life options. Passive euthanasia is legal in all 50 states. However, PAD and euthanasia is not. The Supreme Court ruled that it is the state's decision whether or not to legalize PAD. Oregon's Death with Dignity Act was passed in 1997, Washington in 2008, Montana in 2009, Vermont in 2013, and finally California in 2015. PAD is illegal in all other states. Those involved in the practice of PAD could be punishable under the state's law, and could range from a felony, manslaughter, misdemeanor, automatic prison sentence, or professional discipline resulting in the loss of the medical license. As some of you may know, Dr. Jack Kevorkian was convicted of second-degree murder after he appeared on 60 Minutes and administered a lethal injection to one of his terminally ill patients. Even though his patient requested Dr. Kevorkian's assistance with his death, euthanasia is illegal. Brittany Maynard, a right-to-die champion for herself, argued that she should have the right to choose when and how she died. Her experience sparked my support for the legalization of physician-assisted death. Brittany was 29 years old, had terminal brain cancer, had to move from California to Oregon to utilize their Death with Dignity Act because PAD was not legal in her state at the time. Brittany knew her quality of life would deteriorate and wanted to die with dignity. A year after Brittany's death, California passed their Aid in Dying bill because of her efforts to support PAD for herself. As mentioned before, passive euthanasia is legal in all 50 states. This includes VSED, or voluntary stopping of eating and drinking, withholding or withdrawing from life-sustaining measures, palliative sedation, and using pain medication that could result in death. VSED happens when a patient chooses to stop eating and drinking in order to starve to death. The body eventually dies due to lack of water and nutrition. Although most times this is a painless way to die, there can be complications. When Terri Schiavo's feeding tube was removed, the autopsy showed she suffered severe brain damage in nearly all regions, from death by starvation. Another type of passive euthanasia is withholding and withdrawing from life-sustaining treatments, such as VSED, as I just described, removing feeding tubes, breathing ventilators, or discontinuing dialysis. All life-sustaining attempts are stopped, including CPR, respirators, and artificial nutrition. Another option is palliative sedation. This is when a patient will be sedated using narcotics to the point of unconsciousness to control pain symptoms. Eventually, nature takes over and the patient dies. Using pain medications to hasten death is a legal option in all states and occurs when a patient requires dosages of pain medications that have side effects that could impair breathing and cause death. With all of these options, there is no time frame on how quickly someone dies, because each person responds differently. With PAD, once a patient ingests the lethal medication, death occurs within minutes or hours, painlessly. In the next 2 slides, I will discuss patient characteristics and reasons why patients choose PAD to enhance my support of legalization of this practice. According to several studies of Oregon's Death with Dignity Act, the predominant patients requesting PAD are white, middle-class males between the ages of 65 and 85. Most are married, well-educated, and of the Christian faith. Patients diagnosed with terminal cancer and ALS, also known as Lou Gehrig's disease, were found to consider PAD more often than other terminal illnesses. Shown here is a list of reasons patients request PAD. As you will notice, the top reasons patients request PAD are wanting to control the circumstances of their death, avoiding future poor quality of life, pain, and the inability to care for themselves, loss of independence, and wanting to die at home. If you remember, the passive euthanasia options I discussed earlier all involve the potential of being monitored by a physician in a hospice or hospital environment up until the time of the patient's death. By allowing nature to take its course in the progression of the disease, the patient runs the risk of experiencing the majority of what they wish to avoid, therefore making PAD a more ethical option. This brings us to whether or not PAD is an ethical option. Listed here are the pros and cons of each side of this debate. On the pro side, patients are attempting to escape unbearable suffering. Those who support PAD respect autonomy. They feel terminally ill. Competent persons should be allowed to choose when and how they die. Using PAD is a compassionate response to pain and anguish via a quick and painless death. This anguish and pain is not simply physical pain. It's existential, social, and psychological. Patients are fearing the loss of independence, loss of sense of self, and functional capacities that some feel will jeopardize their dignity. Those who cannot withdraw life-sustaining measures, such as those on respirators or eating via feeding tubes, deserve to have PAD as an option when they cannot just disconnect from life-sustaining technology, such as Brittany Maynard. And lastly, those who are for PAD feel it is a violation of their individual liberty's right to have PAD be an option. On the con side, opposers indicate that PAD runs directly counter to the traditional duty of the physician to preserve life and do no harm. Under the Hippocratic Oath, it states, "They will not administer poison to anyone where asked, and I will be of benefit, or at least do no harm." Those who argue against PAD feel it will undermine the professional integrity between a physician and patient, harming the healing nature that physicians bring to patients. Others say it diminishes the sanctity of life. As well, opponents of PAD say that it is morally allowable and acceptable for a person to refuse treatment or withhold treatment to hasten their death, which is passively letting someone die, but that having a physician provide a means for suicide is morally wrong and an act of active killing or murder. Others fear physician errors, where the diagnosis or prognosis of a patient could be incorrect, allowing someone to self-administer the medication and die in error. Lastly, others promote that if PAD were legal, the potential for abuse of marginalized groups would be high, as well as the risk for coercion and exploitation. Interestingly enough, Coombs-Lee, in a study directed in 2014, found no evidence of heightened risk for the elderly, women, the uninsured, people with little education, the poor, the physically disabled or chronically ill, minors, people with psychiatric illnesses, or racial and ethnic minorities. To counter opponents' arguments, since the passing of Oregon's Death with Dignity Act in 1997, 1,173 people received prescriptions for life-ending medication. 752 have died from ingesting the medication. Over a span of 16 years, that equates to approximately 47 people per year. That is hardly evidence for any type of abuse or overuse of a public policy to have occurred. Therefore, this makes clear that the risk of harm to people to legalize PAD is small when the state authorizes the rights of a competent, terminally ill person to make the decision to self-administer medication for a peaceful and dignified death. Because opponents will continue to argue against PAD, making sure guidelines and safeguards are in place can allow for future states to use Oregon's strict criteria to avoid abuse of the practice of PAD. In addition to what is shown, patients must be at least 18 years of age and also be educated and offered the use of all of other end-of-life options as I described earlier. It is also important to offer clinical criteria for physicians who want to participate in PAD to lessen opponents' fears of abuse, exploitation, and errors of the practice. One thing I would like to point out here on this list of 8 is that patients must be able to self-administer the medication themselves, either by swallowing or pouring into their feeding tube. The family of the patient can help mix the medication, but they cannot dispense it. The patient himself or herself needs to do that on her own. Even though there are other end-of-life options available in each state, a terminally ill person should be permitted to choose when their life ends if they have no chance of being cured or know they will experience intractable suffering in the future. And even though the other options may seem reasonable and ethical in comparison to PAD, these options cannot be guaranteed to be painless and oftentimes requires medical staff to be present to monitor pain and suffering within a hospital or a hospice bedroom. Now that we know deaths at home are associated with significantly better quality of life, and wanting to control the circumstances in death and die at home are among the chief reasons terminally ill persons request PAD, do you support PAD? Debating whether terminally ill patients should be allowed to choose when and how their life ends will continue to be a highly controversial subject. But with the information provided in this presentation, I can say PAD is a safe, effective, and ethical end-of-life option. By legalizing PAD in all 50 states, using the clarifying conditions set forth in this presentation, people suffering from a terminal illness can choose to die with dignity. Thank you very much. Please find the references that I used for this presentation on these last 2 slides.